cannot get an understanding of what any situation is unless you actually go to the person's home.
When medical providers come into your home, you can show them firsthand a slice of your life, the things that you're doing at home, the kinds of equipment that you need.
What I need for my medical supplies are all in my house. When I go to a clinic, they don't have a closet full of ventilator supplies with specific items I need. We're often like, oh, we need to go get this from this lab. And I'm like, but I have it. I know what my needs are, and they can do it here when I can't do it in a clinic.
In earlier modules in this series, we talked about changing the paradigm for delivering care to people with involved disabilities. We looked at how the traditional medical model fails to meet the unique needs of this population and how applying the principles of independent living can provide a roadmap for redesigning care delivery. In this module, we dig deeper into how our healthcare system can better support people to live independently by providing primary care in the consumer's home.
It starts with a recognition that primary care is a service and not a building. Let me relate a story that I've heard many times. For people with spinal cord injuries, a great threat to their autonomy, their independence, and their health, and perhaps life itself, are recurrent complicated urinary tract infections, where there is a probability that this could end up in life-threatening sepsis within 24 to 48 hours. What we hear is that it is impossible to get an immediate appointment for evaluations for all the reasons that I mentioned earlier: the rigidity of an appointment system, the problems with the publicly funded rides. Then we compound that with that what we physicians have been taught was generally not to start an antibiotic empirically without a culture and a more specific bacterial etiology that's been elucidated. And yet what people need here, in contrast to the general population, is really that early, quickest possible start empirically on an antibiotic that has worked in the past. Think about the redesign features and the value redesigns that are needed for that to happen. Taking that sophisticated knowledge of lived experience, viewing in a person that is a partner, not as a supplicant for medical care. We're talking about the use of professionals that change their schedule, simple as that, to put as a top priority a new problem that takes precedent over a scheduled visit. And in this case, we're talking about a situation that moves that decision-making to the home because of the inflexibility and of an appointment system and the barriers to accessing that appointment system.
Bringing the care out into the community was our way of really making care accessible from the consumer's perspective, also to broadening the clinician's understanding of the life experience of that person. So by going into the home, you could see their home situation, you can see whether they have food in their refrigerator, you can see what the living situation is like, meet their caregivers or their family members. Going out into the community and meeting people where they are was a way of personalizing the relationship, humanizing it, and making it just a more equal partnership.
When providers come out to my home, they learn more about me than they would ever learn in a clinic. I had one provider who I had worked with for several years, and it wasn't until right before I ended up on the ventilator that she suddenly realized I had a child. But I had been a parent as long as she knew me. I had even brought my daughter into the clinic with me, but it didn't occur to her that that was my child. She thought I was babysitting. And I'm like, so once you come into my home and you start seeing American Girl dolls everywhere and Legos, those aren't my items. They see me beyond being a wheelchair user.
Despite evidence that home-based primary care improves health and well-being for people who cannot otherwise access care, it remains rare in today's healthcare environment. One recent study found that fewer than 12% of people who were housebound as a result of disability or chronic health conditions reported receiving primary care at home. When these individuals don't receive regular primary care visits, their health problems can worsen, and they can end up in emergency rooms and hospitals, driving up the cost of care. The convenience for patients also helps providers by decreasing the likelihood of a no-show in the office.
I always felt like I could call someone and say, I'm worried about this. How about if I stop by and see you? And it was very unlikely that they would say, no, I don't want you to come. Whereas if I was asking them to come into the office, that might be a different story.
Person-centered home-based primary care should encompass interdisciplinary teams that provide frequent visits to manage chronic conditions, urgent care visits to avert hospitalizations, help with social supports for patients and family caregivers, coordination and management of long-term services and supports. There is evidence that comprehensive home-based care can save money. The Independence at Home program, which is a federal demonstration of comprehensive home-based care, tracked results at 14 sites across the country. Among participating practices, savings of about $3,000 per beneficiary in the first year resulted from reduced hospitalizations. Quality of care improved, and so did patient and family satisfaction.
Prior to July, I spent essentially from January to late April in the hospital, was readmitted May into June, and then 6 more hospitalizations that summer. My care for that year, I know, was well over $1.5 million in a hospital setting. Once I switched over to in-home care, my hospitalizations dramatically went down because the only reason I was ending up in the hospital beyond that point was for sepsis. Medically, I've been far more stable than I had been in years, which is cutting down the amount of specialists I'm having to see on a regular basis. And my primary care physicians are in contact with a specialist, and they know more about me now than they ever did with me just in a clinic-based setting.
To make home visits successful, it's important to consider scheduling, equipment, and logistics. While home care creates new challenges for your practice and for clinicians, there are also enormous benefits.
The clinician has to deal with a lot of conditions that may not be favorable. You're in traffic, you're trying to find parking, it's terrible weather, the cleanliness of where you're going may not be very good. You're going into an environment that is an unknown, but I did feel that it was a much more satisfying way for me as a clinician to provide care. I could make my own schedule, I could spend more time with people, I could sit down with them and really get to know them and not feel the pressure of knowing that there were 5 people in the waiting room waiting for me.
To create a successful home visiting program for people with involved disabilities, giving clinicians flexibility in setting home visit schedules is important.
We always, as clinicians, made our own schedule for home-based care. So we would have a panel of patients that we were responsible for. And it was up to us to prioritize who needed to be seen, to do the follow-up.
Over the years, what empirically was learned is that you need to keep a good part of that day open, because you know you are going to have new problems that need immediate attention. But if you have a person that is getting a 1-month follow-up while they're home, and they're going to be home anyways, and that nurse practitioner now gets a call with somebody that is got a fever, shaking chills, and just feeling sick, that is potentially, where this could potentially be serious, the nurse practitioner will make that decision, change that decision to priority decision. It will go to that person needing the urgent care with a call to the person at home and say, I can't make it. When can I see you at home again? And of course, that person has not given up half their day to go to the office.
For people with involved disabilities, many of whom cannot easily get to a medical appointment, being able to receive primary care at home is imperative to their health.
In the winter, when we don't have sidewalk access, we can't access our providers, so them coming to us makes a world of a difference. But when you point this issue out and they're driving to your house and they're seeing the sidewalks or the curb cuts are full of snow, the sidewalks are clear but the curb cuts are not, they start to get what our actual needs are. It's like, this is what I've been telling you in the clinic and why I keep canceling appointments, because I can't get to you. But now that you see why I can't get to you because you've driven past these barriers and you're now more aware, not only does it make a difference for me, you're going to rethink the needs of other patients that also have physical disabilities and what their barriers may be, even if they're not expressing them.
In this module, we explored the benefits and some of the challenges associated with delivering home-based primary care. We learned that for people with involved disabilities, receiving primary care at home is critical to health and well-being. For clinicians, home-based care provides a deeper knowledge of a consumer's needs, builds trust, and can be a very satisfying part of their practice. With an integrated interdisciplinary team approach to care, home visits add the flexibility necessary to quickly address urgent care needs and avoid complications and hospitalizations.